Today, I'm going to discuss the genetics and update of chronic kidney disease. And this is the complete presentation because I'll present some of this data tomorrow during the activities of the annual conference of the Egyptian Society of Nephrology and Transplantation. To start with, the genetics and the update of chronic kidney disease, although it appears difficult, but it is very important. Why? Because genetic renal disease presents to the mainstream clinicians and nephrologists as a mixture of kidney-specific as well as multi-organ entities. The rapid increase in knowledge and reduced costs of sequencing translate to new and clinical aspects of clinical care and allow testing of the genomics and genetic disorders to be added to the diagnostic armamentarium. And I'm trying to discuss this title under these corners: early onset of chronic kidney disease and the contribution of genetic disease for this group of patients, alternative splicing and its effect on the chronic kidney disease, diabetes, hypertension, hyperuricemia, and the correlation of these diseases and abnormalities with the chronic kidney disease and genetics, renal aging and the relation with the genes, autosomal dominant polycystic kidney, and I'm going to discuss in details some new issues and hot topics regarding the polycystic kidney, and then miscellaneous aspects of kidney disease and genes, and I finish with closure after noting the clinical implication and guidelines for this issue. Regarding early onset chronic kidney disease, this is one of the most important reviews, very interesting, and I advise everybody interested in this topic to read all through this article, because approximately 20% of cases of chronic kidney disease that manifest before the age of 25, which is the definition of early onset chronic kidney disease, are caused by single gene mutation in any one of more than 200 different genes that are already nowadays known. If we look at the different syndromes that can lead to early chronic kidney disease, and I mentioned 20% of them are related to genetic abnormalities, we have congenital anomaly of kidney and urinary tract, and the indication to run a genetic panel is the presence of these anomalies in kidney and urinary tract evident by renal imaging. And here you will find the proportion of cases: obstructive uropathy, renal aplasia, hypoplasia, reflux, etc. And here there are 36 genes that may lead to these congenital anomalies of kidney and urinary tract, and it contributes to 8.5% of all CKD. And then steroid-resistant nephrotic syndrome, and this is the indication, proportion of cases, and here 39 genes. Chronic glomerulonephritis, either lupus or other pathologies, and find 10 genes. For renal cystic ciliopathies, 95 genes. For atypical hemolytic uremic syndrome, 9 genes. Nephrolithiasis and nephrocalcinosis, 30 genes are known. So we have more than 200 genes, just to show you that the monogenic causes are so prevalent: autosomal dominant, autosomal recessive gene mutations, autosomal recessive, autosomal dominant for this syndrome. And for chronic glomerulonephritis, you'll find either autosomal recessive, dominant, or maybe dominant or recessive like Alport, or X-linked like Alport syndrome. For nephronophthisis related ciliopathies, a lot of gene and protein abnormalities can share in these. And again, monogenic causes for renal stones, you'll find a lot of gene abnormalities, protein abnormalities, and disease entities. Another study shows the prevalence of monogenic causes in pediatric patients that are associated with nephrolithiasis and nephrocalcinosis. This study included 143 patients, and they were tested by ultrasound, either that shows nephrocalcinosis or at least they have one episode of nephrolithiasis. And you may have either nephrolithiasis in the majority, 86%, or 14% nephrocalcinosis. At the end of the day, from these 143 patients diagnosed with stones or nephrocalcinosis, 24 cases, this means 16.8% are due to genetic defect, either recessive or dominant. And this is a very interesting monograph, because if you diagnose urinary stone below 1 year, the cause is recessive, and if the age of onset of the disease above 1 year, you may have either dominant or recessive genetic abnormality. Another study showing that the whole exome sequencing identify causative mutation in majority of consanguineous or familial cases who presents with childhood onset increased renal echogenicity. As you see, you have either consanguineous or familial cases, and if this is the situation, 63% here, 63% here are associated with these mutations, either homozygous or here homozygous or compound heterozygous cases. These are families, and this is the gene zygosity, and if you look here, this is a syndrome, nephronophthisis, or as you see here, gene asphyxiating thoracic dystrophy, which is JAT-D, or GBTS in this syndrome, which is Gobert syndrome. Another study showing addressing the genetic loci associated with renal function measures and chronic kidney disease in children, among the pediatric investigation for genetic factors linked with renal progression consortium. A lot of genes, a lot of study, a lot of persons. However, the recommendation at the end of the day, we need to address more genetic testing and further validation of the genetic abnormality. Another study showing that the genomic imbalance may share in chronic kidney disease. Regarding the alternative splicing, this is a very important and interesting. Alternative splicing is the main driver of proteome diversity because we have 20,000 genes that may lead to more than hundreds of thousands of proteome. So splicing is responsible about the different proteome produced by the same gene. And this splicing is the main control for cell phenotype pathogenic splicing process that may lead to different diseases, principally cancer, but may be associated with other diseases like neuromuscular, diabetic cardiomyopathy, and the plethora of splice variants has implicated in chronic kidney disease as well. As I mentioned, human genome consists of 20,000 genes. 94% of the genes can be alternatively spliced, and you will be surprised when you know that nowadays there are 370 diseases are due to this splicing. Just to know splicing is a very intricate and highly organized process that occurs inside the nucleus, because the DNA is exposed, leading to pre-mRNA, formation of pre-mRNA, and the pre-mRNA include exons that can code for protein and introns which doesn't code, introns don't code for protein. So for pre-mRNA to be transferred to the ribosome in the cytoplasm to be translated, pre-mRNA should be spliced to the mature mRNA that leave the nucleus to the ribosomes for the process of translation and the polypeptide formation. The pre-mRNA spliced introns are removed by this process. We have splicing factors and enhancers, exon sequence enhancer, and maybe silencing, and the introns is the same, silencing and enhancer, and the primary aim is to remove the introns, leaving the exons to be translated by ribosomes. So sometimes the cutting occur at different sites. For example, if we look at the vascular endothelial growth factor, we have A form, which is angiogenic, and the B form, which is anti-angiogenic. Inside the glomeruli, there is a balance between these two forms. So, and if you look here, this is the number of amino acids, and all these are A form because splicing site occur here proximal. And this is a B form, which is anti-angiogenic, splicing occur distally. And it is not only the splicing of vascular endothelial growth factor, but its receptor can lead to abnormalities. Soluble clotho, we know the clotho is anti-aging and has antioxidant effect. So we may have different splicing, so we may have different clotho that may carry other functions. And the same for erythropoietin receptor, it is a protein, so we have different splicing for this proteome, for the exons and introns, so we have different forms of the receptor. Some of these receptors are resistant to the action of erythropoietin, and this may explain the resistance in some cases. And the same for fibronectins. So a lot of proteins can be spliced to different proteins that derive the progression of kidney disease. So is there any potential treatment for this abnormal splicing? Yes, we have what's meant by SSOs, which is splicing switching nucleotides, that can switch off splicing at abnormal site and drive splicing toward the normal protein production. It's not only this splicing switching nucleotide, but we have small molecule splice modulators that may inhibit splicing kinase, and we have this drug Sphinx that reacts on this place to decrease the formation of the A form or angiogenic form of vascular endothelial growth factor and keep the balance between A and B. And this is under testing in the prostate cancer and other tumors, and also may be tested in the diabetic kidney disease. And other modulators of protein-protein interactions at splice site, modulator of splice factor RNA interactions, modulator of tertiary RNA structure at the splice site. So maybe in near future, we'll find a lot of drugs fulfilling the criteria of guiding the splicing toward the normal behavior. Regarding these metabolic syndromes, this study shows that we may have predictors of progression of type 2 diabetes, chronic kidney disease, and type 2 diabetes through studying these different nucleotide polymorphisms, and these two types are associated with significant reduction of GFR. And here the study shows that the more the allele the patient has, the worse the outcome of chronic kidney disease, and the more the probability of development of kidney disease. This study shows that the genetic may contribute to the mitochondrial function or dysfunction, leading to progression of kidney disease in type 1 diabetes. A very interesting issue is epigenetic memory. Epigenetics, this is environmental reaction with the genes. So this group of authors demonstrated that high glucose level exerts stimulatory effect on activation histone marks, leading to the abrogation of thyroidoxine interacting proteins gene expression, which is a pro-inflammatory. And they also showed that the effect was reversed by inhibition of histone acetyltransferase. So the first stimulus may lead to epigenetic memory and leading to histone modification. If we can interfere here, we can prevent the prompt response for second stimulus, which may be environmental inflammation, etc. Regarding hypertension pharmacogenomics, this is a very interesting area because it guides the treatment of hypertension toward the personalized medicine. So if we know the locus and the single nucleotide polymorphism for this G alleles, we can predict that G allele is associated with greater blood pressure response. Here you can see the difference in systole and diastolic blood pressure. And adverse cardiovascular outcome, if G allele is present, is associated with reduced cardiovascular outcome in the patients treated with beta blocker and diuretic study. So G alleles, 1 or 2 copies, is associated with increased risk cardiovascular outcome when thiazide diuretic was not included. So if we have G alleles, thiazide is better to be included in the armamentarium of antihypertension of this patient for the sake of better response and lower cardiovascular problems. For beta blockers, we have different alleles that predict the response for different beta blockers. Regarding the hyperuricemia, if you have the genetic problems, regarding this is the genetic marker of hyperuricemia that predict cardiovascular event in a meta-analysis of 3 cohort studies in high-risk patients. So if you have T form, either homozygous or heterozygous, this is a predictive of more cumulative cardiovascular event, even if it is not significant in these, but it's associated with higher cardiovascular problem. And if you look at the incidence rate, it is higher here, 60% in comparison to 3 and 4, in comparison to 1.9, 11 to 6, and here 5.6 in comparison to 2.7. It's not only cardiovascular, but also CKD progression. So the polymorphism in a gene encoding for Urate transporter is associated with CKD progression. And here, if the patient has GG genotype, this means that there is the patient is protected. And if there is T, GT or TT genotype is associated with more deterioration of kidney function because these curves reflects events-free survival. Regarding the aging, as you see, this is the fingerprint of aging on the kidney, tubular atrophy, glomerulosclerosis, and vessel changes, vascular changes. And here, this is the gene, the analyzed phenotype, and the possible function in renal gene. So for this gene, cabalin function reacts as an endocytic receptor of albumin, affecting this tubular absorption, lead to albuminuria. In this gene, CKD is the phenotype, and uromodulin gene influence sodium chloride reabsorption. Overexpression leads to salt-sensitive hypertension. Overexpression also causes age-dependent lesions, tubular casts, and tubular dilatation. This gene is associated with CKD because a defect in the actin binding domain of the gene results in impairment of the glomerular filtration barrier. So the kidney disease and the aging. So, and these are the other different genes, and this is the abnormal phenotypes, either mesangial matrix expansion or inflammation or the influence of lipid metabolism is involved in cardiovascular disease. Regarding polycystic kidney disease, it is one of the most important genetically related disease. Why? Because it is the fourth leading cause of end-stage kidney disease in the United States after diabetes, hypertension, and glomerulonephritis. Polycystic kidney disease ranked to the fourth place, and nowadays on the world there are 3 million patients affected, and it is 1 per thousand. Regarding the natural history, as you see, even if the genetic abnormality is present, usually the presentation in the middle age. So by middle ages, the cyst increases exponentially with the development of chronic and end-stage kidney disease at the end. Regarding cystogenesis, and one of the big conference is this is a summary, because this study addresses the future of polycystic kidney disease research as seen by the 12 Kaplan awardees. And this is one of the product of this paper, is to know the cystogenesis and the contribution of the germline mutation plus environmental factors as gene modifiers, and if we reach the cystogenic threshold, cysts increases. And if you look at the different molecular, the abnormality in the molecular study of the patient with polycystic kidney disease inside the cell, you will find any yellow color means that this parameter is reduced. So calcium is reduced inside the cell. Phosphodiesterase, which is responsible for the hydrolysis of cyclic MB, is also reduced, leading to increasing cyclic MB. That's one of the major contributor to the development of cyst process. Also, motor is enhanced, and the green color here are the treatment. I'm not going to discuss this in detail, but I want to just show you some update regarding the polycystic kidney disease and other molecular problems. So microRNA 21 aggravate cystic growth in this experimental animal model. This is, if you look here, this is the animal model, and this is a knocked out regarding microRNA 21. So you can observe the kidney here are smaller. This means that the cysts are not developed like this form of animal. So the presence of knocking toward microRNA 21, this means deletion and decreasing microRNA 21 is associated with lower kidney volume, smaller volume, lower number of cysts, preservation of the kidney for longer period, and the lower the marker that denote kidney damage like K molecule and NIGAL. Again, I mentioned the phosphodiesterase, which is responsible about the metabolism and hydrolysis of cyclic AMP, and this is regarding phosphodiesterase 1 and 3. By the way, we have 11 families of these phosphodiesterase, and you can find 1 and 3 are associated with more cystic kidney disease, and especially if in this monograph. Regarding the splicing, you can find abnormal splicing that can lead to development of cystogenesis. Renal single gene polymorphism may contribute to progression of autosomal dominant polycystic kidney disease. This is a secreted frizzled-related protein 4 can predict the progression of autosomal dominant polycystic kidney disease. If you look here, the higher the concentration of this protein, which is secreted frizzled-related protein 4, the higher the lower the GFR, and the higher the decline in estimated GFR here, as you see. And this is the, if you categorize them into the into two levels according to the cutoff point 15 nanogram per ml, and this is a time point after 24 and 36 months, 48 months and 60 months. You in both figures, the higher the secreted frizzled-related protein, the higher the progression of chronic kidney disease in polycystic kidney. And this is another study shows that vascular endothelial factor C is associated with beneficial effect, because here this is the rat model treated with vehicle, and this is if the vascular endothelial factor C is given through transperitoneal for this rat. And if you look at the hematoxylin, you'll find if the rat is treated with vascular endothelial factor C, the cysts are lower in volume, and not only the renal cyst, but also the external affection in the heart, lung, liver, and spleen. This table summarizes polycystic kidney disease and hepatorenal fibrocystic diseases. As you see, autosomal dominant polycystic kidney disease is the most common because it's 1 in 1,000 and associated with cyst in liver. This is and affects the entire nephron, and the defect in the gene PKD, polycystin 1 and 2, and this is the hepatic affection, biliary cyst, and the congenital hepatic fibrosis is rare, and systemic fissures are present because it may affect the intestine, heart, etc. In autosomal recessive polycystic kidney disease, the cyst affects collecting duct exclusively, and may be associated with congenital hepatic fibrosis and Caroli syndrome, and this is rare in comparison to the prevalence of other autosomal dominant polycystic kidney disease in adults. You can find a lot of syndromes, nephronophthisis, and you can look at the renal disease, hepatic disease, and this are all these. This is the prevalence of these syndromes. We need to refine the genotype, because there is refinement of genotype, phenotype correlation with autosomal dominant polycystic kidney disease. These are the genotype. We have truncating mutation in the polycystic kidney disease 1 mutation or insertion deletion, and this is the non-truncating, it's 27%, and 30% is polycystic kidney 2. So here the truncating mutations are associated with the high kidney volume, and not only volume but the renal survival and the patient survival are affected by the type of the mutation. Truncating mutation is associated with lower renal survival and patient survival, and this is the age of onset of end-stage kidney disease according to the mutation present. If it is 1 polycystic kidney disease 1, truncating mutation. The age of onset of polycystic kidney disease is 52. Here, insertion deletion 58, sorry, and non-truncating 70 years. PKD2 80 years, 80, and this is unknown mutation 77.5. This is very interesting, and this group should be congratulated for this PKD Foundation, because if you write this link, you will find the data, and you can select PKD1 or PKD2 germline, and you can know the data here. For example, here 2,320 hitting mutations, and this is a table that shows everything, and you can look at germline and somatic mutation for PKD1 and PKD2. Practically, we have the ultrasound criteria and revised unified criteria for diagnosis and exclusion criteria for polycystic kidney disease. So the age and the number of the cysts are the ruling for the diagnosis. This study carries a very important, interesting data about what's known as PROPKD score. What's PROPKD score? This is a new algorithm to predict renal survival in autosomal dominant polycystic kidney disease. So genetic and kidney disease update as the title of the presentation. It depends upon these four variables: sex, hypertension before the age of 35, the presence of more than one or equal one urological event before the age of 35, and the type of mutation. So if the patient is female, this is 0 point, and if the patient is male, the patient is offered 1 point. So this means that the progression of male polycystic kidney disease is higher than female. I know that the cyst in liver is associated with female more than male. Hypertension before the age of 35, if it is present, yes, this is awarded 2 points. If urologic abnormality below 35 years, another 2 points. And for the mutation, if it is PKD2, this carries this offered 0 point. If it is non-truncating type of mutation, it's 2. But if it is truncating mutation, it is 4. So truncating mutation is very important, crucial for the prognosis. And if you look here at the cumulative probability of survival to end-stage kidney disease, it occurs earlier. End-stage kidney disease occur earlier if the patient has high score, if it is 7 to 9. Again, the patients are stratified according to this risk calculation into low risk group, intermediate risk group, and high risk group. Intermediate risk group, if the patient points of this, again, this score is from 0 to 3, and intermediate score and intermediate prognosis, if the score is 4 to 6, and if it's above 6, 7 to 9, this group of patients carries the worst prognosis and severest form. And if you look at the reduction of the GFR according to the scoring, if the score is low, this is a drop of the GFR, and if it is intermediate, this is a drop, and if it is the score is high, this is the highest drop of GFR per year. Then, at the end of the article, this is the algorithm. You should ask yourself, if the age below or above 35, if there is any clinical presentations or hypertension before, and at the end of the day, you may follow the PROPKD score or you follow the genetic scoring. It seems that the genetic testing and genetic profile, the tendency toward the genetic testing is increasing. Regarding the urinary biomarkers, we have the urinary biomarkers like NGAL or kidney injury molecule that can predict the injury. Other innovations in the radiology, in the MRI, this is the spatial prior probability and then pre-processing to have this automated augmentation that helps to guide the management of polycystic kidney, because currently we depend on the manual assessment of the kidney volume. And this from another university, from Mayo Clinic. Regarding liver involvement in polycystic kidney disease, hepatomegaly may start even before the evolution of the cyst inside the liver by ultrasound. And this is very interesting because we can diagnose with a confidence the infection. The gold standard for infection in the cyst is by diagnostic aspiration, but as you see, these are the different modalities that can be used. This is for renal, hepatic, and all cases. And if you look, we have ultrasonography, CT scan, contrast-enhanced CT, MRI, contrast-enhanced MRI, diffusion-weighted images, and 18 fluorodeoxyglucose positron emission tomography. And if you look here, the definite for diagnosis is 100% in these cases. So it's, again, this is very nice to be used for diagnosis of probable and definite pathology, and can help us, and it may be sufficient if we cannot do cystic aspiration. Regarding the total volume in autosomal dominant polycystic kidney disease, as I mentioned, polycystic kidney disease affects kidney primarily by cyst and liver also as well subsequently. And if we estimate the volume of kidney and liver, this will give us the total volume. The bigger the volume, the lower and the limitation of the efficacy of polycystic kidney disease of peritoneal dialysis for these patients. Another important theory that came from the experimental animal study showed that this experimental model of the polycystic kidney disease and if you compare, this is the rats fed on the food restriction and find a bigger, lower volume in comparison to the ad libitum fed regularly, and this is hematoxylin eosine. We find cystic index increased here. Ad libitum is the role in feeding. If you restrict the calories, the hematoxylin eosine shows lower cystic volume and the lower cystic index, and this is significantly present if you drastically reduce the calories. Although it is difficult to transfer 40% or 20% food restriction, calorie restriction for human being, but nowadays the scientists are concentrating on what is known food restriction mimetic classes of drugs. If we diagnose polycystic kidney disease early, because autosomal dominant polycystic kidney disease is usually diagnosed in adulthood, but sometimes the diagnosis is carried out in utero if we find large echogenic kidneys with normal amniotic fluid level. Postnatally, the increased echogenicity disappears and the cysts become detectable by ultrasonography. Individuals with autosomal dominant polycystic diagnosed in utero or during the first year of life have more aggressive polycystic kidney disease with increased cyst burden, renal complication, and hypertension. As we know, the quality of life in polycystic kidney disease is affected drastically by the presence of pain. And here, this slide summarizes the cause of pain in polycystic kidney disease, because pain is caused by either because of cyst rupture, cyst or kidney infection, chronic kidney pain owing to renal enlargement, and nephrolithiasis, pain from diverticulitis, gastroesophageal reflux is also more commonly seen in autosomal dominant polycystic kidney disease. Chronic pain has a significant negative effect on quality of life in these patients, and the management include analgesics, avoidance of strenuous exercise, cyst aspiration or sclerosis, cyst deroofing procedures, selective nerve blocks, and renal denervation procedures. This slide summarizes the difference of presentation of autosomal dominant polycystic kidney disease in adults and children. If you look here, this is different. Hematuria is more common in adult. Congenital defects are more common in adult. Hepatic cysts are more common in adult. And the presence of hypertension before renal function decline is more common in adult. Mitral valve prolapse is more common in adults. The pathogenesis of hypertension is related to the abnormality in endothelial function, cardiac carotid abnormalities, renal cystic formation and expansion, At the end of the day, this is associated with increased angiotensin II formation and increased action, and the action lead to increasing aldosterone, increased sodium retention, increased vascular resistance, increasing fibrosis and increased mitosis, and all this at the end of the day lead to hypertension. By the way, the best class of antihypertensive treatment is angiotensin converting enzyme inhibitors or angiotensin receptor blocker, and calcium channel blocker should be put in mind to be the last resort of treatment, because as I mentioned in the cystogenesis that there is calcium defect inside the cells. Sometimes you need to screen for cerebral aneurysm, especially for patients with history of neurological problems or families with history of stroke. But to generalize screening for the presence of cerebral aneurysm for all patients with autosomal dominant polycystic kidney disease is not convincing. This is genetic counseling guidelines. From these guidelines, they recommend that adult patients diagnosed with autosomal dominant polycystic kidney disease are referred to their regional genetics service for genetic counseling if they are interested in and would like to discuss the following: inheritance pattern, molecular genetic testing, family planning. And the same here, they recommend adult at risk of autosomal dominant polycystic kidney disease are referred to their regional genetic service for genetic counseling if they are interested in and would like to discuss inheritance, predictive testing, and associated issues, family planning. And these are the guidelines for genetic counseling. Although I was against the genetic counseling because it will create headache, especially if we have families coming with children. So why we screen children? But currently, after the thorough reading, and if I put my hand on the concentration defects, hypertension, I can aggressively manage the risk factor for the development. So I am nowadays convinced with genetic counseling, but still we need strong evidence to generalize this policy. But for the donors, I think for relative donor coming with polycystic kidney and end-stage kidney disease patients, I think it's rational to look at the exclusion criteria by radiology plus genetic testing if available. Regarding the intimal this is another the miscellaneous issues of gene and kidney affection. For regarding the molecular mechanism of hemodialysis vascular access failure, we have a lot of problems. Genes and the protein expression abnormalities may share in this cause. De novo deletion in the regulator of complement activation cluster producing a hybrid complement factor H and complement factor H related 3 gene can lead to atypical hemolytic uremic syndrome. In the Japanese study showed that interleukin 6 receptor gene may be associated, and the author detected novel single nucleotide polymorphism in the interleukin 6 receptor gene that correlates with CKD in reasonably large Japanese cohort of patients. Another study showed that interleukin 6 and the functional polymorphism in interleukin 6 gene is associated with cardiovascular events, and you can find here the higher the interleukin 6, the higher the cumulative risk, and the presence of this genotype shows higher risk and the cumulative risk. Regarding the APOL1 gene, which is prevalent in African American, if the 2 risk alleles are present, this increases the glomerular and FSGS in HIV patients, and again kidney disease and cardiovascular disease and death in older adults. And this is relatively recent, and this is a recent publication this month. Regarding the uromodulin kidney disease that is related to uromodulin kidney gene abnormalities, which is responsible for horseful protein. You can look here, the proteins are accumulated inside the cells, so it leads to this problem of chronic kidney disease, and you might find a clue by lower level of this horseful protein in the blood and in the urine. As you see here, this is the serum horseful protein concentration. For patients with abnormalities in this gene, you'll find lower level, and also in urine. MicroRNA and renal fibrosis Again, microRNA, a lot of secrets are belonging to this microRNAs. Here, for example, TGF-beta stimulates some of microRNAs like 21, 192, and 433, and these microRNA are incriminated in the renal fibrosis, and it inhibits other microRNA. So we have some microRNA which are proved to be foes and friend. Regarding the tubular interstitial kidney disease, we have the term autosomal dominant tubular interstitial kidney disease. This proposed terminology, and this is a gene, causal gene, and this is a previous used terminology. You can read all these. And there is a difference even in the age onset, in the onset of the age of this disease. In autosomal dominant interstitial kidney disease, it occurs in the 4th or 6th decade in comparison to these other syndromes. We have abnormalities in this mutation, the transient receptor potential cation channel subfamily may be associated with FSGS. Regarding the RAS genes, this study shows that the role of renin, angiotensin-aldosterone system genes in the progression of chronic kidney disease as a finding from the chronic renal insufficiency cohort study. An interesting study shows that the genetic African ancestry is associated with phosphate excretion. So the patients coming from African ancestry have lower filtration fraction of phosphorus and higher serum phosphorus. Regarding the implications, I think that if we know the genetic related disease by genetic testing, this may provide a definitive diagnosis and place the clinical phenotype into context and potentially facilitates delivery of personalized medicine. If you know the genes, you can deal with the persons. Might enable precise genetic counseling for family planning, might enable diagnosis of affected family members, and enable unnecessary and diagnostic procedure test and the treatment to be avoided. For example, if we diagnose familial FSGS, there is no need to do plasmapheresis before the transplantation. Early detection and treatment of asymptomatic or subtle extrarenal manifestation like cystinosis, and you can deal with extrarenal affection, provide guidance for monitoring of potential future complications, and guide advanced medical management on gene-specific therapy. For transplant preparation, the European Renal Best Practice Guideline don't recommend living donation from a genetically related donor in patients who are suspected to have atypical hemolytic uremic syndrome at their underlying kidney disease unless the responsible mutation has been conclusively excluded in the donor. This, although it is, there is no strong evidence in literature, but it's a recommendation. And this suggests that children with steroid-resistant nephrotic syndrome undergo appropriate genotyping before waitlisting them for kidney transplantation. And these are the CARI guidelines shown. I think I discussed this with the polycystic kidney disease. For patients with diagnosis of polycystic kidney disease or at risk of polycystic kidney disease, we can discuss these different aspects as I mentioned in the sector of polycystic kidney disease. To conclude, I think the novel genetic causes carries a new dimension in the diagnosis of genetically related disease. And this protocol, I think it's a very ambitious protocol because it discusses the different and diagnose the different genetic testing, offering the genetic testing to diagnose the novel genetic causes of kidney disease. Moreover, it will validate because these authors from Australia withdraw another sample of blood to create a nephron dish, the disease in dish, by allowing the indissoluble pluripotent stem cell to evolve to nephron. And so they test the validation of the gene, the phenotypic abnormality in the nephron related to the gene discovered in this study. So we are waiting the result of these protocols. Although the nephrogenetics are exciting, we still, to end, this is the last slide, we have limitation and challenges. The limitation from the study design, from the phenotypic, genotypic heterogeneity, ethical problems regarding the genetic testing, lack of cost-effective analysis, and the limited availability and the lack of education and the orientation of the general population and doctors. And I think if we have good study that shows that the genetic related diseases is the same like cancer breast, if we detect breast cancer antigen 1 and 2 genes in a patient with post-family history like Angelina Jolie, which is a known and famous actress that was convinced by her doctor's speech about the value of bilateral prophylactic mastectomy. And it raised this issue, does Angelina Jolie affect medicine more, even more than publication in the first prestigious journals? I think we still have gaps that should be explained in your future, and I hope that I summarize the issue of genetic and chronic kidney disease as I can. Thank you very much for your attention.